Welcome to the latest episode of the Global Perspectives on Digital Health podcast. Today, we are going to be talking to Echo Vanderwal, who is the Executive Director of the Luke Commission, who run healthcare services within Eswatini, a country in Southern Africa. We're going to be hearing about how they solve problems for people and enabled clinicians, community health workers to deliver higher quality care through a people-centered approach. I'm very, very excited to have their insights, and I'm sure we'll have a lot to learn. Let's get into it. Echo, it's so nice to have you on the podcast. Thank you for taking the time to be with us here and share your insights. We had Dino from Aldere on the podcast a couple of months ago, and he, after the podcast, said, "Hey, Shubs, if you want to get some real insights on implementation and really hear about some exciting work, then you've got to speak to Echo at the Luke Commission." So kind of after a few conversations that we've had together, I'm very, very happy that you've taken the time to come and speak to us and share your experience. Welcome to the Global Perspectives on Digital Health podcast.
Thank you very much, Shubs. Thanks for having me here.
Why don't we start with the origins of the Luke Commission and maybe your story as well? It would be really good to hear about that and kind of what got you into this.
Okay. All right. Well, actually, when I was 8 years old, I felt called to work in healthcare in Africa. I had heard a story of someone who was working in Africa, and I just felt called to that. And I know I was just a kid, but it stuck. And then my husband, similarly, when he was 17, he felt a similar calling. And then we met when we were 19 and went to undergrad and graduate school. He's an internal medicine and pediatrics doctor, and my background is a mid-level practitioner in surgery and pediatrics. So in 2004, someone invited us to Eswatini, and we had, maybe back up just a little bit, when my husband was in residency, we had triplets, boys, and then in 2004, we had number 4. And when he was 2 months old, someone gave us contacts in Eswatini. And so for the first time, we got a passport. I'd never traveled overseas before. And we flew to Eswatini, and we didn't know exactly what we were dropping into, but we dropped into the middle of the HIV pandemic. And someone took us immediately out to a rural area. And in literally every homestead we went to, we found people dying from HIV, young people. And we started asking what were the barriers to people getting access to healthcare. And there were 2 main barriers that everyone talked about: was lack of transport being expensive for people who didn't have jobs. And the second one that they talked about is that when they went to health facilities, they felt stigmatized. And so we started to realize very early on that compassion was going to be very critical if we wanted to work here. So we then moved here full-time, and this is our 20th year in Eswatini. And we've raised 6 kids here, had 2 subsequently since we've been here. But we started first going to the rural areas for the first 8 years. My husband and I were the only medical professionals, and we worked with a team of about 20 local staff. And we learned so much because we were literally like getting the dust on our shoes of every single chiefdom in the country. And it's very true, when you walk with the people, you learn the challenges intimately. And then in 2013, up until that point, we just did mobile outreaches in rural communities. In fact, at the height of the HIV pandemic, we were testing 250 people a day positive for HIV. And at that time, we didn't have good access to antiretrovirals. So of those 250 people, we would have to choose only 5 that were allowed to go on antiretrovirals. That's how things were at the beginning of the HIV pandemic. So it was, very, very difficult, but a very, very fulfilling work. We really enjoyed it. And then 2013, there were doors open for us to be able to buy land in the center of the country. So we bought 70 hectares. And since then, the team's grown a lot. We are a team of 700 now. And last year, the team took care of 300,000 patients. So it's kind of very humble beginnings, but very important to get feet on the ground and understand intimately what the people were going through, and then be able to. We eventually established a fixed site facility at the Miracle Campus, the site that I'm talking about now. And it's been just really a joy to see things grow and the staff grow, and it's been very fulfilling.
So you bought this land in 2013. And as I understand, you use this to create a center for delivering healthcare, right? And can you tell us a little bit about that and kind of how that enabled access?
Sure. Well, the land was a huge blessing because it actually borders our biggest river in Eswatini, and we were able to secure a kilometer of riverfront with the acquisition. And it's also on one of the very main roads going north to south in the country. So having access to a main road and to the river has been very helpful to be able to establish a robust site for centralized supply chain hub for all of the teams that go out to the country, as well as a referral center of excellence. So we do a lot of specialty care and tertiary care here. We are the largest provider of ICU care in the country, and also we do a lot of specialty surgeries. And so the other thing that has happened here is that we've also developed all of our own support teams. So we have engineering, biomed, fleet maintenance. We build all of our own buildings. They've built 25 buildings, and they've done an amazing job developing this place. It's really, I just find when people build something themselves, they own it, and so you can just see an ownership from the team. That is something that I don't see often, and so it's a special team, I can say that.
Yeah.
But now this site, as I mentioned, is the referral center for all of the outreach teams as well as from the other facilities in the country.
Echo, you mentioned the barriers to care that people were having. Can you paint a picture of what in Eswatini problems were day to day for people?
Sure. Well, I think that, just understanding kind of the personality of, or the underlying personality type of the country is also very important because we're a shy, quiet, and non-confrontational country. So when you offend me, I will not tell you. And what we heard very early on when we were moving in the chiefdoms is that people would say, if I have to be treated like that, let me go home and die. And then you start to realize, like, this is a big deal. It's not like Europe or the United States where maybe somebody will file a complaint and go to administration, and then there will be some corrective action and things will change. People weren't reporting these things to a centralized place where it could enact change. They were going home and dying, and they were leaving behind so many children. And of course, the devastation from that in our country, when at one stage, 20% of our country was orphaned from HIV. So, just understanding the socioeconomic impact when you don't work at root level on some of these issues. I think sometimes too, we bypass how important person-centered care is, how important compassion is in the engagement, the patient health provider engagement. But it really, for us, has been the key. When you are working side by side, journeying with the patient, it's a much different outcome than when the healthcare provider is like on kind of on top of the equation. And so that was key for us to realize how critical compassion is, and then to learn how to develop a culture of compassion in our organization. Because just because you identify it as a problem doesn't mean that your staff do that. So we've been very intentional about that and started an onboarding process that's about 10 weeks long. And during that 10-week process, then there's a lot of things that happen in that 10-week process. We do leadership development, personal development, but we also inculcate a culture of compassion. What does it look like to take care of somebody like your own family member? And that's really been key for us because that's something anywhere in the world can relate to. Like, how do you want your mom taken care of? Okay, remember, every person that sits in front of you is either your mother, father, brother, sister, or child. Like, they are somehow related to you through the people that they're related to. So that helped us a lot as an organization.
This training was for people delivering care, right? Community health workers, clinicians, etc.,
Actually,
or everyone.
everyone. Yep. We learned that even if somebody's in a ward fixing a ventilator and they're next to the bed of a patient, they need to have the same culture. So it's not just your people that are providing direct care. And, at times we've had even construction projects happening next to where patients are admitted. And so you realize, oh no, it's your construction workers too. They need to understand compassion. So it's really helped us because the whole team is united around this culture of compassion. And then on the issue of transport, I wish I could tell you after 20 years that challenge has dissipated, and it hasn't. Because for the most vulnerable, if you don't have any income at all, what are you going to choose? Whatever little meager resources you have, you're going to feed the kids who are crying at your feet for food. You are not going to board a bus and go to a hospital, and you will only board a bus and go to a hospital when you're at advanced care stage. So that's one of the reasons we've prioritized so much going to the people. And this is highly logistical. I mean, our teams are, depending on the sites they're at, they can be anywhere from 5 to 50 or 60 staff. Sometimes they see 500 patients a day in one community, and it's all really driven by the digital ecosystem, which I'm sure you'll raise a little bit later, so I won't go into that right now. But the coordination and logistics has been really important to going to the people, and then we also find who needs to be referred to more specialized care. So it allows us a kind of a funnel to figure out who can be treated at community level and who needs to be brought in. But I'll tell you what, I wish I would have known this at the beginning. I don't know what it might have changed, but the thing that I've learned over the past 20 years is actually the biggest issue and the biggest barrier is lack of accountability and transparency in our supply chains. And that one issue is actually disrupting access to care. I think probably not just in Eswatini, probably in our entire continent, and I'm sure in many other places in the world. So I do think that for us, the introduction 7 years ago of digital systems to provide accountability, controls, and transparency in our organization has just elevated the trust of this institution so much in our small country because they know our supply chain is reliable. And I think that's the thing that keeps people away from not seeking healthcare early in disease, because they have learned that when they go, they're not going to get the medications that they were supposed to get when they went to the doctor. So then they say, well, if I don't get medications, what's the reason to go? And then they only come when things are at an advanced stage. So I do believe, especially in our country, that this is something that we have to take very seriously because we're unnecessarily losing the lives of people. So, it's of course evolving over time of figuring out what the barriers are, but I do think that definitely the last one is solvable. Probably transport will always have to bridge the gap. And, I do think there's been some work done in just person-centered care that's more talked about now than it was when we first started here. But the part about supply chain, I think, will be heavily impacted by an embracing of digital systems.
That's a really nice segue. And so just to connect some dots, you talked about the problems that were faced by people accessing care. Sometimes we think about these as just, okay, what's locally affecting them in terms of what's going on in their life. But I think what you've highlighted is the systemic ecosystem problems that then contribute to their experience of care and the kind of the knock-on effects of them kind of losing trust in the system. I think that's such a great takeaway. So you set up this ability to deliver care. So you set up the physical infrastructure. Around this, you enabled people to deliver care in a compassionate way. You looked at logistics and supply chain. So kind of infrastructure, looking at people, processes, and kind of the other part to this is then how did you look at then technology? Sometimes as humans we look at shiny new technology and say, hey, let's like shoehorn this in. So how did you think about and prioritize? You've alluded to this a little bit. How did you prioritize? Okay, we have the opportunity to use technology. Where is it going to be most impactful for us? How do we do this? Because I guess there's lots of learning to take to health system leaders around the world to say, hey, we've created this infrastructure, we've created a way to deliver care, and now we have the opportunity to leverage technology to do this even more impactfully. And you've had lots of learnings around how to do this. So,
well, Shoops, it wasn't like we said, there's shiny technology over there, let's go use it. We had pain points. We had things where we were very dedicated to process workflow and to time and motion. We didn't want people waiting any longer than they needed to, and we had really high volumes at the sites that we worked at. But the challenge was we had pain points as we scaled. And the initial pain point that we identified is that the scheduling is a real challenge in a spreadsheet. So how can we build a system to ensure that the right people at the right place at the right time doing the right thing? You get those four key components together, and you've solved 80% of your challenges. That's what we found. So initially, we built a scheduling system. It wasn't our intention to build this big, huge ecosystem that it ended up being. We just started with scheduling. And then after that was working well, we're like, wow, this makes life so much easier. What's our next biggest pain point? And then we would just take the next biggest pain point and we would build a module for it. And then the next biggest pain point, we build a module for it. And the thing that was really great about our developers is that they recognized from day one that user feedback is critical. So we've been able to be in kind of like this leapfrog type of approach to development because they are so close to the users. And I mean, during COVID, our developers would put on PPE and come on the ward with us. At the height of COVID, we had 138 people admitted and 91 in the ICU and 55 on ventilators. So it was moving, like it was very busy. And they would come in and they would watch our time in motion and they would go outside and they would write code. And 30 minutes later, we would be using that code in the ward. So when you have your development,
talk about a fast feedback. That's a fast feedback loop. Totally.
I mean, when they are so close and embedded with the team, it's amazing how fast the development process can work. Because when the team feels like they can give feedback and their feedback is heard, doesn't mean that 100% of what we say happens. It doesn't mean it all happens in 30 minutes. It doesn't. But there's a dev queue and things get put in the dev queue and the development team is very intimate with our operations and they see things that are very critical and those things go right away. So once the team sees that, oh, my feedback matters, they just give you more and more good intel, because it's true, users know best. And I think what we've seen happen with other systems in our environment is that a lot of the developers are not in the country and they're not intimate with the challenges. And it's very easy to become disconnected from the reality on the ground. But because our developers were connected to the reality on the ground, it really changed our ability to scale and bring digital solutions to ground level. So it's been really fun to watch the process. But I think there were some key learnings that I think could be taken to other environments that could be helpful. And one of them for me was, I'm not a tech person, but I understand how much tech impacts patient care and service delivery. In our case, it's patient care, but it's service delivery no matter where you're at. And simplifying administration was so important for us because once you simplify administration in the healthcare context, you're able then to put a lot more effort into caring for people. The compassion becomes easier because the system is empowering compassion. And these are the things that we've seen. I mean, it's really been fun. It's been hard and it's been intense, but it's really been fun to watch the dynamics in the team. And I think that just the unity that I see in the team is very much drives some of the ability to do this rapid development. The buy-in, because their voice is heard, brings more good ideas to the table. And it's like the developers don't have to go searching for good ideas. They're brought by the end users. So the other thing that I think that I probably need to say right from the beginning is that we prioritize this system being mobile first. Why? Because we realize that the relationship between the patient and the provider is the most important part of the whole equation of our service delivery. And what we found in a lot of other countries is that, in the first world, most of the time, these systems are built for billing. They're built from that perspective. In our environment, systems are built for grant reporting. They're built from that office. And the patient is kind of a second thought. In this case, they developed a system from the bedside of the patient. And that has allowed, I think, there to be a different product at the end of this process.
And this was an EHR for the provider, for the community health workers to deliver care and kind of solve some of their administrative issues. Is that right?
Well, there's three main pillars. One is supply chain, one is HR, okay, and one for and service delivery, which in our case is the EHR.
You've touched on so much that I wanted to get into. The first one is the importance of the fast feedback loop and having your developers really understand it. The design and development team really being as close to what's going on the ground as possible. The second is it's sometimes hard, at least in my experience, it's hard to get feedback that matters from end users. And so what is the way to unlock that engagement with it? And it's really like kind of building that trust and kind of having that fast feedback loop. Hey, actually, this is being heard. I know that if I engage with this, even though I have such a busy day, and I'm so focused on this, I know that I'll invest this little bit of time giving this feedback, and it will pay off because it's gonna improve what I'm doing and my ability to deliver care. So I think that's such a nice nugget and then such a nice takeaway. And then I just wanted to call out the thing that you mentioned, the frustration in the US, the EU, the UK around EHRs and the problems with usability of these and how they kind of take people away from kind of delivering care and like you're just kind of on your computer, like not focusing on the person in front of you. And it's really interesting that that plays out in a similar. Everyone complains about EHRs in the US kind of built for billing, and so I really like this parallel that you called out. That it's same but different. It kind of plays out in a different way where historically for you it's been geared towards grant reporting, right? And so the way you then solve that in a similar mindset, but for kind of a related problem, really stands out.
Thanks a lot. And the other thing that I wanted to say is that we really have found that if it's right for the patient, it's right for grant reporting. If it's right for the patient, it's right for billing. I just think sometimes when we have a problem, we forget the perspective where we're supposed to solve that problem from. And
Yeah.
I mean, we've had people come from all over the world. I mean, shoots, people are coming here right now. We have 3 tours going on, just coming to look at the system in action. And these people are from all outside of the country. Yesterday, same thing was happening. It just is every day people are coming from all over the world to look at the system. And we didn't think we were developing anything special. We were just solving our little problems we thought on the ground. And when people come, I mean, people that really know what they're talking about, they say things that I can't believe. Like one political advisor from from Washington D.C., but he worked next to the president in Rwanda during their economic recovery after the genocide. He came here and did a tour, and we went and sat in a debrief. And the first thing he said is, "Do you know that this digital system that you built can change the GDP of countries?" I was like, "What?" Like your perspective is just different when you're in your own little environment solving your own little problems. You don't realize that maybe you built something that can solve problems in other places. And recently we had a surgeon here from the United States who said, "I'm going to go back to my CEO at our hospital network and tell them that the EHR that I used here is better than Epic." Okay, maybe I shouldn't have said the name, but that's what he said. Those are, you start
You
to
can say.
realize, yeah, I didn't know that we were building something special, but you start to realize just by getting the perspective of other people from around the world who really are in places where they have exposure that, yeah, maybe it is special.
What you just mentioned about this surgeon taking you away and what you've done here back to the US is, to me, in a nutshell, like why we reach out to you and have these conversations on this podcast. So you've just kind of summed up the whole why of the podcast in that little sentence. So that's really, really great. And kudos to you and the team for focusing on that. There are books and seminars and conferences that talk about, fall in love with the problem. It's really about the problem and and there's lots of great academic theory about this, but it's really interesting that still implementation suffers from really getting that bit really nailed down before you then kind of try to scale, right? And so I think this is really good learning. You you just worked with the people who are delivering care and solved their problems and made it work for them and iteratively, and kind of then went back, very fast feedback loop. So yeah, I think that's a great message for the sector as a whole in digital health, of how you really just kind of make it work on the ground. So great.
Maybe before you shift gears, I wanted to go back to the part of getting user feedback.
Yeah.
I wanted to share a little bit, I think, of what was maybe part of the secret sauce that could be shared and maybe help someone else. From early on in the organizational structure, we tried to keep it flat. We wanted to hear from everyone. whether it's the gardener, the cleaner, the security guards. And I'll be honest with you, they've brought us some of the most valuable feedback that we've gotten from anyone. So I think one key takeaway for us has been just to make sure that your leadership team, no matter how big they are, no matter how many qualifications they have, that they understand how important it is to also learn every day. In our core values, one of our core values is teachability, which means that no matter who we are, we can learn from anyone in the organization. And most importantly, we learn from our beneficiaries, in this case, our patients. And I remember early on, we were building the digital system. We actually have a plant manager here. He manages our plant equipment. And he's been here, I think he's probably been here 11 years. He's been here a long time. But he had probably been here maybe about 5 years at the time. And he said to us, if I was a patient at the gate, I would not like ABC 123. And he told us that there were things that he wouldn't like. And the team took that information and completely changed the way that process happened. And, I look at that today and say, what if we would have never had that feedback? Would we still be making those same mistakes that we made? And so that's been a key takeaway for us, is just to hear from everyone. Everyone's feedback is valuable. It's not just the leaders, it's not just management, it's not just the technical people, it's not the people who have qualifications, but make sure, we have really tried to create these feedback loops from everyone, even patients. So after every patient checks out, they get a text message and it says, were you happy with your service today? If not, press 2. If yes, press 1. And as soon as they push 2, it creates a task in a task management system that one of our senior managers picks up immediately. Sometimes they haven't even walked out of the gate. Sometimes we can correct our mistake before they even leave site. And, I call them patient whisperers. They call with a really nice voice, and the patient tells them a lot of things maybe we needed to fix. And then that allows us to do real-time corrections and not wait till the end of a month for a report or when something has really escalated. So I think, those feedback loops have been critical to us, just to be able, the real-time correction thing I think is really critical. Before we're 45 degrees out, we are only 1 or 2 degrees out, we're able to easily correct.
I think that's so interesting that you've done that intrinsically and seen the value of it. One of the things that regulation is trying to do is make this kind of thing mandatory. I mean, not trying to do, it does, right? We, in some degree, they call this kind of post-market surveillance. So you deploy and then you monitor qualitatively and quantitatively. Mm-hmm. And a lot of people say, hey, this is so onerous and da-da-da, right? No, I'm not calling anyone out in particular, but that can be the attitude, right? And what you've done is said, well, we're going to invest in doing this because it actually helps us produce a better service and product. And we use this to actually actively look at how we can improve things. And so for me, that's another great message around the value of taking this and not just kind of paying lip service to, we take your feedback really importantly. It's actually a part of your development and improvement, continuous improvement. So that sounds great. Have you had any challenges or things that didn't go so well that you've learned from?
Every day. Maybe I can say we've had a lot of challenges, but the second core value in our organization is looks for solutions. And these core values, we actually recite them every morning in our divisions. We stand in a circle, we go over our mission, our vision, our core values, our creed. And, it sounds kind of like, I don't know, child stuff or something like that, or elementary school. But to be honest with you, Shoops, it's made a difference. It somehow refocuses us. No matter what happens, no matter what situation happens, you're like, refocus. Okay, this is what we're about. This is why we're here. That number 2, looks for solutions, has been key, because now in our induction program, we train that we know that we're going to run across challenges every day, but we believe as a team that we can get together and find solutions for whatever challenge is in front of us. And that has really changed, kind of the approach to challenges. So I definitely, we've had a lot of challenges. We couldn't, that were difficult, but possibly it's that core value that has been inculcated in the team, that when they see challenges, they start talking about possible solutions rather than the challenge. And it's very much a team approach to solving problems. So sometimes when something good happens and somebody says, well, how did that happen? I couldn't even tell you who was the originator, because probably 5% came from one person, 10 from another, and 15 from another, And I think that really helps with the team unity as well. It also helps people throw out more ideas because they don't have to come up with the 100% idea. But wow, some of our challenges, maybe one of our current ones, is that we really struggled we have really solved the supply chain thing internally. I can tell you that. We have a super strong end-to-end supply chain accountability system from procurement all the way to dispensing drugs to the patient. Really, nothing moves without it being visualized in the system. But we then started just taking on more and more of the national healthcare system burden and did not plan well for how we were going to resource that. Also, this happened during COVID when there was a lot of crises on the ground. We also had unprecedented civil unrest during COVID. So there was a lot of things happening. And, I would say one of our challenges we're still in the process of solving is how do we balance the demand now? Because when you have a high quality service with a robust supply chain, then the demand just keeps getting bigger and bigger. So it's almost like some of the things that happened were too successful and we didn't maybe hedge the growth fast enough. It happened very fast. Like the number of patients we're taking care of has grown by 300% over the last 5 years. That, I think that's probably hard in any context, let alone a low resource, environment context. So that's one thing that we're still working on. And that's one of the reasons that we're starting to diversify some of the things. We're really working on a totally different funding model. We're a nonprofit and we have never charged for our services, partially because remember where we started. We started in rural areas where no one had healthcare. And we knew that if we charge the poorest of the poor for healthcare, there's one thing that will happen. They will stay home and die. That's what happens. So if any one of us don't acknowledge that, we've missed our social contract with the most vulnerable. So I do think it's important to understand that. Now at our facility, we have people that are coming that could pay, but we don't know who those people are because our facility is seeing 1,000 patients a day. Like how do you determine who they are? So those are some of the current challenges that we're working on solving is, being able to have a way that through an API, you can reference, some vulnerability index so that you know whether or not people should pay or not pay. Because for us as an institution, and of course it's different in other spaces, but if we charge the poorest of the poor, we've broken our social contract with our mandate. And it's just like a non-negotiable for us. So we have to figure this out. And, these are some of the things that we're currently working on because we didn't realize that some of the efficiencies that we put into place were going to drive demand at such a level that it was a mismatch with resources.
You talked about going to the people and you've set up the ability to deliver telehealth in the most rural or hard to access areas. Can you tell us a little bit about that?
Well, I think if we're honest with ourselves, telehealth is being used in first world countries very well. And it's really efficient. If somebody doesn't have to leave work or somebody that doesn't have to leave home, and it's just efficient for everyone. And it works a lot of the times. But what we realized is that in a context like we're working in, people are boarding buses, again, going back to the transport issue, and they're spending those bigger resources that they could be using to put their kids in school, or they could be using to buy their children food or for other things. And they're boarding buses to come to hospitals to get 10 paracetamols or 10 ibuprofens, things that you and I have in our homes. Not only that, they're coming for routine refills of antiretrovirals or routine refills of TB drugs or things that they don't really need to be seen in person for if there's not labs due or other things. So we started feeling about 4 or 5 years ago that what if we took telehealth to communities? And some of this was driven during the civil unrest that we had because some of the facilities were closing and we were trying to figure out if you had to mobilize quickly in a crisis, how would you do that in a high quality way? So we started working several years ago on this telehealth hub concept, which we've just finished a prototype and are working on 3 more actually now to roll out. And we hope that this goes big. We really do, because we feel that it's special. And it's integrated with Livelo, the digital system that I've been talking about. Just side note that Livelo in our language in Eswatini means compassion. And we also felt like it was a word that could easily be said around the world. So that's why we chose that word. But we literally have taken a shipping container, a 12-meter shipping container, and we have fitted these shipping containers with solar. They're completely off grid. And we use Starlink for connectivity. And there's literally 4 bays. The first bay, you go inside, you self-register on a digital device. The second bay, we have a vital scanner that is integrated with Livelo, and you get your vitals. And we really feel as clinicians, if we could get a good set of vitals, we can pretty much know whether or not which direction we need to go in for the patient. In the third bay, you do a video consult with a doctor who's at our headquarters. And as soon as the doctor orders the medication, it sends the patient a once-off PIN. And then they go to the screen and they put in their once-off PIN, and then out comes their medication out of a vending machine. Behind the scenes, we've customized a vending machine for high volume, high SKU commodities. We want there to be, we want it to solve a lot of problems. For instance, if we take somebody's blood pressure, we can actually do blood pressure medication adjustments even at remote sites. So we've been working on this for a very long time and have just recently, getting ready to take it out. In fact, we haven't launched it in our country yet, but we will soon.
You mentioned right care at the right place at the right time, and so this, I guess, seems like an enabler of that, right? So you're creating capacity by all those people that otherwise would be coming centrally, who just needed refills or just needed those situations, and you're like dealing with them at source, which is great for them. That's great for you as a system. That's great for your clinicians who are freed up to see the people that they need to. So a great example of like solving across the spectrum. So you said it's not live yet, because I was going to ask what the adoption like was that of that. So have you done some trials of that, or have you done some?
We have,
or is it kind of out? Yeah.
Mm-hmm. Yeah, we're trialing it inside of our network first, and then we are planning to. We're already in conversations with some potential customers for this solution. So yeah, it's really fun to finally have it at the stage it's at.
And I was going to ask, how do you solve the connectivity issue? So you mentioned Starlink. How did you manage to get Starlink to agree to connect you guys up to the grid or to the?
Well, the Starlink process all went through the regulation process, the regulatory process in Eswatini, and it was approved in Eswatini. So then it was easy for us to be able to connect to via Starlink. We do know, for instance, our neighbors in South Africa, they haven't approved it yet, and some other countries haven't. But this is a game changer. We're the first to tell you that this is a game changer. We use about 1,500 digital devices a day to do our work, and we have teams all over the country. And being able to use Starlink, we just use Starlink with solar panels now at all of our remote sites. All those generators, the need for electricity, all that stuff is just gone, and the connectivity is much better than even our local service provider for cellular service.
I think it's a great. So it kind of harks back to something Bilal said from Digital Square in the podcast, and something I've heard before, where you can have all this tech and you can have all these great services that you're doing, but it needs the infrastructure. Just how you can create the best train in the world, but if the rails are crap, then that's not going to be great. So having the infrastructure as a way that that enables you to do all of this, you need reliable connectivity to be able to deliver that service. If it's going to work, you need that. So yeah, I can see how that's in your words a game changer. Yeah, amazing.
That's been a game changer, and now there's we're doing some installations for some of the other facilities, and so it's really exciting. We're a bit of an innovation hub or an incubation hub or petri dish, whatever you want to call it. We're not really scared to try something and fail. Maybe if I could put it to you that way, or try something and have to go Rev 2, 3, 4, 5. And so it's fun then once you've been able to find a solution for our network, then be able to take that other places and see the way that it transforms their operations too is really fun. That's really what we want to do. Moving forward, we would like our technical teams to be able to go out and take some of these innovations to other places, other countries, not just in Eswatini. And hopefully that will help us to solve some of our challenges, which is, we're looking for other revenue generators to continue doing our core work.
Amazing. Speaking of not being afraid of innovation, can you tell us about drones?
Well, I'm really excited to tell this story because you know how sometimes there's artificial barriers in some of the engagements that you have with different regulatory units, and sometimes it makes sense, but you just can't get it through the regulatory process. What I can tell you is that in Eswatini, we've had the most amazing relationship and process with the Civil Aviation Authority. And I don't think most countries can say that. So I really want to champion their willingness to do something they've never done before, because we are the first approved drone network in the country. They didn't even have the regulations in place. There were things that they didn't have in place. But what I loved is that they knew what our goals were. It was to get high value commodities, vaccines, drugs, anti-venom, snakebite anti-venom, blood units, and reverse logistics for lab samples. Those are our goals. And they know that that was important, especially in rural communities. And they just focused on solutions. And our team and their team worked side by side, and just literally every single regulatory component that had to be in place, they worked together to do it. And it's just been the most amazing relationship. And I've said, even in the launch, I said that if all relationships were like this, we would achieve so much, because again, the focus was on the end goal. And then everyone in between where we were at and where we needed to get to be said, how do we solve these problems? Because it's good for our people. And so, yeah, I was really, really thrilled just to see this come to fruition and get through all the regulatory process. And more importantly, the focus of the Civil Aviation Authority on solutions, the objectivity by which they engaged in the entire process. I think it's a model that, beyond getting drones in the sky, how are we able to do this so quickly in Eswatini? It's a case study that needs to be looked at.
That sounds really, really interesting. We've had several podcasts talking about the regulation and the problems from both angles, in terms of the ability to have regulation as a facilitator and enabler, rather than just like being perceived as, hey, it's there to block stuff, right?
Yeah.
And also the attitude of developers and people who are building technology, to say, hey, we don't necessarily need to like skirt around it and say, oh, how can I avoid the regulatory conversation? But actually lean in to talk to a regulator, say, hey, here's the impact that we want to have. How do we do this in a way that feels good for everyone? And so how do you have the right level of safeguards and guardrails, and how do we work that out together? Because I think this is a really good model for how we're thinking about AI and LLMs and etc. Like, you've leaned into it, they've leaned into it, with the thing of like, what's the need for delivering this for people. So yeah, definitely think that should be a case study. So relevant.
It's been really fun. They all came to the launch and they were as excited as we were. It was just really such a joint achievement. And I think no matter if it's internally and you're working together as a team and you achieve something big, or you're working with external stakeholders and you achieve something big, there's some euphoria that comes from a really tight collaborative process. So, I mean, the facilities are so excited. It's also, of course, driven by the fact that we have strong supply chain, supplying those drones. And literally within an hour of them making their orders, those drones are landing. In fact, I think they've done like half of their targets for the whole year in 2 months.
I wanted to touch on two things. You started with the problem, and I just wanted to understand this a bit better. There are certain types of medications that might be controlled, or that you need to dispatch very, very quickly. So you mentioned antivenom and certain types of controlled drugs that will be impactful in the right places. But A, might need a level of protection where you need to keep them centrally and then get them out to people. But B, they're so rare and valuable, like antivenom. And there's that kind of the time criticality. Like, if you've been bitten by a snake, and you need very, very quickly to understand and get that person that antivenom. And you already mentioned the problems of the transport issues, Do you have anything more to say around how did you identify those? I mean, it seems like a no-brainer looking at it retrospectively, but yeah, any more comments on that problem?
Well, we do a lot of snake bite work in the country. In fact, we're the main referral hospital for all the snake bites. This year, we've admitted over 400 snake bites alone. We have not had one snake bite death, really driven by really strong treatment algorithms. And the time and motion is critical. How do we make sure that we don't over inject antivenom? It's very expensive. It has its own side effects. So, balancing that. And how do you make sure that you don't miss early signs of severe envenomation or progressing symptomatology that needs response? So we've had really strong treatment algorithms and a team that's really wanted to solve this problem. We were sick and tired. We have black mambas in our area. We were just sick and tired of seeing people die from these neurotoxic snakes. And one of our friends, I call her a snake whisperer. She loves snakes and she loves people. So she's worked really hard to bring awareness to the country. And she's told me five or 6 years ago, she said, Echo, if you have ventilators and you put neurotoxic snake bites on ventilators, if for some reason there's no antivenom or for some reason they come too late and they're severely decompensated, you'll save them. And I was like, well, if that's what it takes, we're getting ventilators. And so we did. That's why we started our ICU. It was because of snake bites. And I'm telling you, we haven't lost a neurotoxic bite in the last 3 years because if people are severely decompensated, we ventilate them. And guess what? After that venom neutralizes, 3 or 4 days later, they come off the vent and it's as if they were never bitten. But before, they would die. And that's what everybody in the whole country thought was, if you get bitten by a black mamba, it's a death sentence. The doctors used to tell people, just say your goodbyes, especially because they bite kids a lot. So to say that to the parents, it's just like devastating. And we got sick and tired of that, Shubes. And we just decided, like, we're going to try to do something different, even if everyone says that there's no way to avoid this. And over the past 5 years, we've just gone from not only less or to no deaths in our own facility. For the first time in recorded history this year, we have not had a snake bite death in our country. So I do think, rapid access to antivenom played a major role in us wanting to get drones in the sky because last year, 2 years ago, we had 25 people die en route. Last year, we had 9 people die en route. We're like, this is just not necessary. But the problem is when you send, as you said, this very expensive commodity out to 400 facilities, it leaks. It's expensive. It's valuable outside of the hospital, And additionally to that, it's not only that, it's oxytocin and other things that save lives. But again, if they're not in the right place at the right time, they're not going to save anybody's lives. They're just part of our supply chain challenges that we struggle with day to day. So that's why we felt that hubbing high value commodities at one place where there's a very robust supply chain, strong controls and accountability would work. And boy, is it exciting, to now have this happening where you get a call. I mean, literally, an hour and a half trip turns into 13 minutes, and these drones fly at night, and 4 kgs is a lot. The payload's 4 kgs, so and these are the initial ones we're starting with. We hope to diversify our fleet over time, but this is, our initial plan is to run this four drone fleet this year and see, of course, how we make it as efficient as possible. But boy, it's been exciting to close the last mile. It's been exciting in the snakebite program not to have deaths. They're just things that you never thought possible 5 years ago. So to reflect back on that and see the change, is really, really exciting.
So amazing to hear the impact of that. Some detractors might say, hey, look, drones, they're great technology, but you need the maintenance, you need the infrastructure. There's how about kind of maintaining, issues around them. You need pilots, they need to be trained, they need to maintain their license. There's all of that challenge. And, Eswatini is a small country. How do you tackle this?
Like everything else, local capacity. And that was a non-negotiable when we were talking to the drone manufacturers, because many of them send in their own pilots, their own technicians, their own maintenance teams, their own ground operators, and it's a service provider type of engagement. And we just said, if we're going to do this, it's a non-negotiable that we're going to develop local capacity and we're going to have our own pilots. And the companies that didn't want to do that, we just couldn't consider them as part of our 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 options. So what we did is what we've done in a lot of circumstances is that when there's an opportunity, we look at the people who've been faithful in the past, and then we start talking to staff who have shown great potential and say, you know what, we're starting this new program. Would you be interested in becoming one of the trained pilots for this program? So it's not people that we bring in to perform a skill. We bring in someone who's already showed that they are sold out to the mission and vision, because that person will, it doesn't matter where you put them, they will do well. Why? They're bought into the big goal. They're not bought into their own personal space. So what we did, we chose 5 people and we sent them to South African flight schools. And it's pretty interesting because they had to go for testing a lot. It was a lot more than I thought it was going to be. I think they took about 12 tests or so like that. And interestingly enough, they all scored in the top 1% in those flight schools. I was very shocked to see how well they did. And then they came back and boy shoots, they owned that program. I'm telling you, it's not just getting the qualification, it's also getting the heart behind what you're trying to accomplish. So that's why I say that what has worked with the drones is what has worked in every other circumstance, is get people who are sold out to what you're trying to accomplish. And if they don't have the training, upskill them, get them the training, get them the qualification, and they're the ones that will then make that next big idea a success.
Great takeaway. Great takeaway. Before we start to wrap up, and you've shared so much, I wanted to go into kind of some kind of bigger meta challenges, as it were. A lot of one of the big things that enables you to carry out your work is funding, and part of getting funding is making sure that you're regularly communicating a very, very clear vision about what you're doing and communicating your impact effectively. Do you have any learnings on challenges or successes for people who might be trying to do the same?
Well, if I could tell you we've solved the funding equation, we haven't. Part of it is because of the scale at which things have grown. And I'll be honest with you, we're better innovators than we are salespeople. So it's something where we are working very hard to solve. In fact, we've brought on a business development team and marketers this year. We've never had that before, but it just the thing got so big. Like, there's no way we're going to be able to do this without getting these teams right. And so we're kind of in the process of doing that. But if I was starting over again, I would have done this much earlier. But we're working really hard to bring up social enterprise lines so that we can continue doing what we feel called to, and doing it in a way that is properly resourced. So sorry I can't bring a solution to that one. I hope someone listening to this will have a solution from me.
Great. You also have like this really, really clear vision and set of values. Do you have any advice on like how to help people create their own for the impact that they intend to?
Well, maybe if I could tell you, don't look at everyone else's.
Okay.
Sit down and have consultations with your team and say, okay, it looks like we created something special here. Why is it special? And start, to figure out what does that look like for you? Because I think our core values, initially I was like, these are a little bit weird. I mean, like, not normal. They weren't weird at all. They were just not normal. And, because the first one's teachability around, humility and how you approach the learning process and making sure even your senior leaders are learners first. The second one looks for solutions. The third one is commitment to unity. Boy, I did not realize how critical that was, but you can look back now and reflect and see how critical that was. Number 4 is dedicated to every last one. We don't leave any patient in line. And, because people board buses and come long distances, and then we say, oh, sorry, we're done for the day. And then it breaks the trust of the patient. So that's really linked to trust. Our number 5 is servanthood, making sure that we understand that the patient is number one in the equation. We're not number one as a staff, the patient's number one. And number 6 is an attitude of gratefulness, because we learned that if we are grateful for what we do have, even while we're working on the things where we have challenges, that it brings a positivity to the environment that actually catalyzes innovation, catalyzes good ideas, catalyzes people to be able to share things that they might not otherwise be able to share in more of a negative environment. So I would say those, I've not seen those core values kind of organized like that before, but they've been super transformational to us to actually say, this is what's important to us and this is what we want to unite around. So I think that would be it. Listen to everybody on every level in your team, and what do they see as important to the institution or the entity. And that ended up being very helpful to us in kind of swallowing my preconceived notions of maybe what a set of core values should look like, and say it's okay if they're different. Obviously it's not
Great.
something you can change, so if you make a big, if it's a flop, then you start over again. And
Yeah, yeah. It always evolves as well. Do you have any final kind of words of wisdom, experience, insight that you could give?
Oh, maybe just two. When I wish I would have learned a lot earlier is like, if you get to 80%, just jump off the cliff and work on the 20% while you're in motion. I kind of am a perfectionist, so it's a little bit hard sometimes to do that. But I've realized how critical it is, because if I don't jump off the cliff with the 80%, I have 0%. And just really
Yeah,
understanding how critical that was important. I think the second thing is to dream beyond what you can see, because that's where we found the really big things happen that you don't expect. And obviously, like, we're a faith-based institution, so we do see God as part of the equation, and we believe that we need to live beyond what we can see, because there's a lot that could happen beyond what we can visualize. So we've tried to dream big and then work together to accomplish those dreams together. And we've seen a lot of those dreams come true. And so it just encourage others to also kind of not put yourself in a box. I remember, I don't know, I trained in medicine about 10 years ago. Maybe I told our CFO that I wish I would have gone into business and got an MBA. And he's like, no, Echo, if you would have done that, you used to be sitting in your office worried about making a mistake. Like, I think sometimes also just ensuring that we look at the sweet spots of our staff and position them accordingly, because sometimes what they were trained in is not what they're best at or what they're naturally gifted at. So those are some of the things that have been really key for us in our organizational growth. And yeah, I really
great.
appreciate the opportunity to be able to talk today, Shubes.
That dream big and beyond what you can see is a really nice takeaway that can apply across any philosophy or kind of theistic belief. So that's a great one. Echo, how can people get in touch with you to and reach out to you if they need to, or be of value to you?
Oh, thanks a lot. And thanks for listening. And Shoops, thanks a lot for having us. If you want to reach out to us, you can reach out to us at info@luvelo, LUVELO.org, or at info@lucommission.org. And we're also on the web under those same URLs. But yeah, we'd love to connect to anyone who thinks they would like to be part of what we're doing or want to connect in any other way. Yeah, we're really excited for the opportunity to be on today. Thanks a lot.
Echo, thank you for sharing such a rich set of insights and learnings. There's so much to take away from people, processes, quality, delivery of care, technology perspective, and also kind of around leadership and values. So much to take, whatever part of digital health or kind of impact you want to create. So really, really grateful for that, and I'm hoping that people get as much out of it as I have today. So thank you so much.
Thank you. Thanks a lot.